Welcome to OVIDcasts. I'm Roudie Shafie, partner here at OVID Health. Welcome to episode 3 of our series in discussion with David Salisbury. Welcome, David.
Hello.
So, David, we've had some really interesting conversations so far about the big picture in terms of vaccines development and also slightly more niche around the JCVI. Today, I'd like to talk about coverage. And the UK has historically had a really good, almost world-leading coverage rate in vaccines. It's something the government was really proud of during COVID. We didn't see the same levels of vaccines hesitancy, for instance, or infrastructure challenges that other countries might have. So what do you think? Are we still world-leading?
I think you have to wind the clock back a bit to probably 2012 to 2014, when the Andrew Lansley changes to the NHS started to have effect. And there has been a progressive slide in vaccine coverage since then. And I think that the changes that he put in place made the delivery and the measurement of immunization coverage actually more difficult. Put on top of that the pandemic, and that had a number of effects. Firstly, coverage for children fell. And of course it was going to, because there were so many interruptions, so much perturbation of the delivery of healthcare. People didn't really want to take their children to an environment where there were potentially ill people who might infect their children. And so it got much more difficult to get routine vaccine coverage up where it should be. So there has been a slide in routine vaccine coverage. Similarly, programs that were being delivered in school were going to be victims of school absenteeism for all of the reasons that we understand. Catching up those missed cohorts is going to be really important, particularly for HPV. The older the target population gets, the more difficult it is actually to get high coverage. To get high coverage of 12 and 13-year-olds, because they're all in school, they're much more easily identified, is one thing. Once they start to not be attending school to the same degree, it's much harder to get catch up for the older missed cohorts. And that's going to be true for all of the age groups, infants, preschool, where they have had gaps in coverage. Those have all got to be caught up again. So there has been a slide. Some things were done, of course, extremely well, and targeting the over 65s, then the over 50s, and then the people in the risk groups for their COVID vaccinations was a great success. It was a great success at the time when there was a lot of disease. And so what you had was a background of a great deal of public fear, because we saw every evening on the news the awful scenes from intensive care units, the awful statistics. Now, under those circumstances, high coverage is almost a given. What's much harder is to maintain that high coverage when that public fear is evaporating. And I think we see that in the proportion of people who have been recommended for a third dose or even recommended for a fourth dose, and they're lower and lower. And it's nothing to do with the three things: having enough vaccine, having enough people to be vaccinated, and having people who will be vaccinated. It's because the perception of risk is changing over time, and the perception of risk is much, much lower now. So keeping the success will be a challenge.
That's really fascinating. You know, for us as health communicators in particular, you know, during the pandemic, we took on some interesting projects to address some potential challenges and using sort of nudge theory and other communication tools to get people forward. But certainly the appetite and commission for that work has significantly reduced as people go back to business as usual. And one of those areas we're hearing a lot about is, of course, NHS recovery. And do you see anything in this kind of idea of kind of recovery? Are there sufficient programs to then catch up with missed immunisation, particularly with the cohorts you've mentioned?
I think there is a high level awareness amongst those who are responsible at national and indeed local level about getting coverage, routine coverage back up and catching up those who have missed. I think that the awareness level is high. It's not an easy thing to tackle, particularly at a time when there are so many other health priorities. Everybody knows that there are people with cancer who are on waiting lists that they shouldn't really be on because they need to be dealt with much more quickly. Everybody knows that there are huge delays for orthopedic surgery. And so immunization is a bit of a Cinderella in that it's a routine community provided program and it doesn't have some of the resources or in the past. Maybe that will change with a much higher awareness in government of the value of prevention, but nevertheless, there's a lot to do to catch up lost ground.
Okay, so prevention is the fairy godmother.
Well, I hope so. And, you know, we hear the words from the political community. That needs to be translated into deliverables, which usually mean money and resources. And it's not just money, it's people to do the work.
Absolutely, absolutely. And you mentioned the infamous Lansley reforms. Those are now all but rowed back. We have the new ICSs now with a legal footing. Does that new structure bring hope in terms of taking kind of mass immunization back to the levels it was before?
I'd rather wait and see. Clearly, those changes were not helpful. And the ones following the Lansley recommendations, I have real trouble calling them reforms because I don't think they helped. So let's wait. I think we have to wait and see. There's been so many structural changes. There have been structural changes in the way primary care is managed, structural changes in the relationships between government, its organizations, and providers. I think we have to just give that a chance. And also, there have been many changes in the translation from Public Health England to the Health Security Agency and its relationship with the NHS. So again, we're in a position of change. I like to be optimistic and think the change is going to be to make things better, but we have to watch, measure, and then decide.
One of the things that won't change will be this continued political desire to be world leading on vaccination. The success of the COVID vaccines program is still, you know, the government is still making hay over it. So the other aspect to that is, of course, the UK vaccine schedule. Is that still right? Do you still think the UK is world leading with comparable countries in terms of the number of vaccines recommended on it? Or is there room for improvement? A great example of that is, of course, chickenpox vaccines.
Yeah, I mean, the number of vaccines in the UK program, I think, is right. I don't think we're missing any that ought to be there, and for whatever reason, we don't have. Chickenpox is one that keeps coming back for debate. The reason that the UK chose not to put in routine chickenpox vaccination was a concern that if you vaccinated young children against chickenpox and you suppressed but didn't interrupt transmission of the chickenpox virus, what you would do is to push the age of infection to older people. And the risks of chickenpox are higher with increasing age. And so instead of children having, for the greater part, an annoying but relatively harmless infection, you would be having iller older people. And it was that balance, and it's based on a prediction. And other countries that have indeed introduced chickenpox vaccine have not seen a push to older age groups. So I think this is something that will have to come back again and again and be reviewed. And I don't know which outcome will happen, whether we continue not using routine chickenpox vaccine, or we then say, okay, it is now time to do that. Now, the driver for that decision is the MMR vaccine uptake, because chickenpox vaccine is going to be given at the same time as MMR vaccine. And so if you've got doubts about your MMR vaccine uptake, it's going to tell you that it's very unlikely that you'll get higher uptake for chickenpox vaccine than you got for MMR, and it might even be lower. So MMR will be the arbiter of whether it is safe to change policy. I think it's work in progress.
That's such a fascinating and complex policy dynamic. One of the interesting things with the chickenpox vaccine, of course, is that people can choose to pay for it at an individual level. Now, we at OVID Health, in our latest round of vaccines public attitude polling we've done, have found a sizable and overwhelming majority of people think that all vaccines should be free, and we tested it against a range of disease areas. And so as a point of principle, do you think that's right? Do you think people should be able to pay for vaccines? Chickenpox, an example. In the past, we've seen meningitis B as another vaccine people could purchase. And of course, what are the implications of that for health inequalities, which we've talked about before, and linking it to people's ability to pay?
It's a complex issue, and my belief firmly is that no one should have to pay for a recommended vaccine. And that I think should underpin everything. And that's not always the case in other countries. In other countries, vaccines can be recommended, but not reimbursed. So you do end up saying, okay, well, the government has advised me, but nevertheless, they won't pay for it. That's, to me, pretty uncomfortable. And so I do believe that where there is a national recommendation, it should be available for everybody. I think you then have to look at the other side of the coin and say, well, if it hasn't been recommended, is there a reason why it hasn't been recommended? And for chickenpox, I think I've explained why the recommendation has not been made for a universal vaccination. So that means that the individual is making a choice to protect their own child, but it may not be necessarily in the interests of the wider community if it had adverse consequences. So it is difficult. You're right that it does open the door to say, if you can afford it, you have it, and if you can't afford it, you don't. But I think you have to set that against our vision for our immunization programs, is that our vision is that they benefit everybody, and they benefit the recipient and our community. And so that's when it gets difficult about saying you should be able to buy vaccine, even though there isn't a national recommendation for it. It applies to flu, where flu vaccine is recommended where it is indeed cost effective. And that's been looked at repeatedly by age. And so I recall that debate came up, should we be lowering the age of recommendation for seasonal flu vaccine from 65 to, let's say, 55. And anybody who's between 55 and 65, for instance, with a risk factor is already on the list. So if you take out those people and you say, well, what's the cost effectiveness of vaccinating healthy 55 to 65? And the answer was it wasn't cost effective. And our policies in this country are driven by cost effectiveness. So that's why we have that sort of disparity between wanting personal protection, which of course you can get for flu. You can go along to a chemist and get yourself vaccinated as you pay for your flu vaccine. Yes. Or you're in a risk group by age or by risk factor, and you get free vaccine again. So by and large, I am comfortable with that sort of arrangement. You raised also the meningitis group B, where there was a huge public response to pushing Parliament to debate whether the age of the recommendation for meningitis B vaccine should be lifted, based on the tragic death of a little girl who was over the age of the recommendation for routine vaccination. And I think, to the credit of our parliamentarians, they listened to a great deal of evidence and personal stories, and said at the conclusion that they were not expert to make such recommendations, and they did have independent expert advice from the JCVI. And the real world was that you have to do the best, but you can't do everything. And I think that they actually gave a good, balanced view that said cost effectiveness underpins a great deal of what we are able to do. You know, if you spend money in a way that is not cost effective, you are withholding money from something that might be more cost effective. You know, if a budget is finite, there's only a limited amount you can do with it before you use up all your money. So you need to use it for the best purposes. And I think that if people were more aware that if you use money in an uneconomic way, you are withholding it from where it may be actually better used.
I think that a balance of thought exists in the UK. I think the challenge comes from the slightly narrow view of cost effectiveness. And again, you know, the flu example is a great one. You could argue that you could increase flu vaccine uptake in those vulnerable people between 55 and 65 if it was simpler to understand. And therefore, one of the things the COVID vaccines drive did, it was very simple. Everyone knows their age. Everyone knows when their age group was called, and they went in. And I think thinking slightly more around the dynamics, around making sure the people who really need it get the vaccine are not unreasonable things to consider in some of this decision making. And I think, again, going back to chickenpox, you're absolutely right. There's the right of the individual. And we've talked about some of the health kind of implications of ability to pay as a driver when you get your child vaccinated. But there's also a question about your ability to take time off work to look after, for instance, sick children. And I know sort of it's very complex. And can you really codify all of that and the cost effectiveness? It's certainly worth reconsidering. And I think, in particular, Parliament, as you said, is a good vehicle to consider some of these more individual sort of stories.
Well, I'm not sure about that. I prefer to think that those decisions, those recommendations, come from those who've given a very large quantity of their lives to becoming expert in those topics. I think that putting that sort of debate to Parliament is no different, actually, to doing a survey of the public, because Parliament has no expertise in this regard. They are only voices, the same as anyone else's voices. You speak about the flu and the age indication, and you're right, of course, everybody knows their age. And that might appear a simple solution, but I think it doesn't deal with an inherent problem that we face. And we have really good coverage, you know, of the order of 75% coverage, which is, you know, better than most other European, if not all other European countries, for instance. So, you know, our flu vaccine coverage for the 65 and overs is really good.
Yes.
And it's of the order of 75%, and that's great. What is so much more difficult is to get coverage of those less than 65 with risk factors, and that hovers around 50%, and it's really stuck. Now, even if you said everybody aged 50 upwards, would that shift the people who really matter aged 50 upwards who've got risk factors when they have not shifted previously? And these people know that they've got risk factors. It's not that they don't know that they've got immunosuppression. It's not that they don't know that that they've got severe liver disease. They know they have, and they still don't take flu vaccines seriously. And so I think that before we spend money on the people without risk factors who are younger than 65, we need to find a better solution for those who really need to be vaccinated and get that in place. Now, I have a thought about this, and I have no reason to be able to evidence it, but the people who've got those risk factors, for the greater part, get their care from secondary and tertiary care rather than from primary care. And there's an interesting split in that if you've got diabetes, you're of the order of 8 times more likely to die from flu than if you didn't. If you've got liver disease or immunosuppression, you're of the order of 50 times more likely to die of flu. Most of the care for diabetics comes from primary care. Most of the care for people with severe immunosuppression or severe liver disease comes from secondary or tertiary care. We ought to be better at providing flu vaccine at the point of care for the people with the risk factors. And so if they're getting their medical care in secondary or tertiary care, then when they go, they ought to be able to have their flu vaccine over the flu vaccine season. And so spreading the responsibility for implementation of vaccination for people with risk factors, I think might help improve that 50% up towards the 75%. But just saying, let's open the door to everybody age 50 to 65 doesn't solve the problem of the people who need it most, who previously have not been good at responding, now changing their behavior.
Well, there's clearly a lot of room to explore for options and solutions. So thank you very much. And this brings us to the end of episode 3.